What's going on, everybody? Welcome to yet another episode of the Core Consults RX podcast. And I was a little busy, so I didn't get the camera stuff set up like I was trying to. So AJ's just chilling up here with us today on camera, getting some FaceTime, much deserved.
Yeah.
Hopefully making the podcast look better.
Well, he usually has his own camera, so this is really a step down because he's having to share it with us.
That is true, but it's okay. AJ, how's school going?
It's going. As long as it keeps going. We'll
Yeah.
right.
You back in the swing of it now?
Oh, yeah.
Good. Cool. Everything on your end?
It's good. We had some new students start this month.
Did you?
Excited, yeah.
I had one as well.
Good.
I didn't realize if it's a younger sister of a student that I had like 4 or 5 years ago.
No way.
Yeah, and I didn't put the two and two together as far as the last name goes. And then she's like, "Yeah, my sister." And I was like, "Oh yeah, now I realize you guys look identical."
I remember having rotations. So my brother was in med school a couple years, or we were at the same time that I was in pharmacy school. But they start rotations earlier than us. Mm-hmm. So he rotated with and worked with some pharmacists that ended up being my preceptors, and it ended up okay.
That's cool.
Well, he's really smart, so they all had high expectations, but I was able to carry his name pretty far with those rotations.
Cole, I think you're smart, dude.
Thank you, Mike.
Yeah, no problem, dude. Hey, Jay, say something nice about Cole.
It's there. He's there.
So today we are going to do another episode that is accredited, thanks to our friends at freece.com. We are going to be covering menstruation-related disorders. Everything from amenorrhea to dysmenorrhea. We're going to discuss PCOS. So obviously none of these are going to be in super in-depth, the content will kind of stay more summary, but we're going to try to cover several different topics tonight, all in the same episode. So if you are a freece.com unlimited member, then make sure after you listen to the episode, there will be a link in the show notes, or you can just go to their website and look at the content. You'll see podcast as a whole kind of learning module now under the tab Learn. You can click there as well, or the show notes will have the link. And then that will take you to the episode or the list of our episodes. Click on this one, and then it'll ask you for a password, which is going to be hormone, all capital letters, and that will allow you to do the post-activity test. After that, you'll get your 1 hour of ACPE-Accredited continuing education to use towards your renewal for your license, that is. If you are not a Free CE member, we obviously encourage you to check out their unlimited membership. They've been running some really good deals right now as far as the price. There's also a discount code that you can utilize even after those prices are over, where you can get a membership at a discounted price by using our passcode that'll be in the show notes as well. And they have a ton of content. You will never get bored, so definitely make sure you check them out. And we appreciate them for continuing to work with us. So, you guys want to get this topic rolling?
Yeah, let's do it. It's been a while since we've done a women's health that I can recall.
I think so.
Yeah.
I think last time we made the joke of like, why are the three of us doing women's health? And then we didn't take our own advice and kind of waited till too late to schedule a female co-host for this episode. So sorry, y'all. We're going to do our best and bear with us.
We say that every time.
We do. I know.
Yeah.
I should just ask my wife to be on the podcast. That would have been
an idea.
That would have been nice. But she's downstairs feeding her son, so it's okay. Well, she gets a pass too.
Priorities. She's got to know that the podcast is more important.
Yeah, that is true. We need to establish that now.
You got to establish boundaries. So like Mike said, we're going to touch on multiple different disorders. We'll start with amenorrhea. For those of you who paid attention in your medical terminology class, obviously that is lack of menstruation. Specifically, no menstrual bleeding over a 90-day period is kind of how they diagnose it. There's primary and secondary amenorrhea. Primary is less common and might be more concerning in a adolescent, but it's absence of menses by age 15 in women who have never menstruated before. So that's why it's primary. This is less than 0.1% of the general population, not super common. Then secondary amenorrhea would be absence of menses for 3 months in a woman with prior regular cycles, or for 6 months in someone with irregular menses previously. So a little more common, 3 to 4% of the general population. It occurs more frequently in women who are under 25 years old, and also it's more likely if they have a history of menstrual irregularities. as well as those involved in competitive athletics. And we'll talk about that a little bit as we go.
And I think one of the important things to remember is that amenorrhea itself is sort of the sign of a disorder, but not a definitive diagnosis.
Right.
Typically caused by an underlying etiology that we need to address and hopefully fix in order to get the menstrual cycle back on track. So some broad categories of amenorrhea etiology include anatomical causes. That could be everything from pregnancy, which is creates a very quick fix to the problem or the concern, or gives you a definitive answer to the concern of amenorrhea. Hopefully, that's usually the first thing we do in clinic is do a pregnancy test.
Yeah.
Because that is a much better outcome in most cases than thinking something horrible is going on. So make sure you don't forget the standard pregnancy test, but also could be, uterine structural abnormalities, things like that as well. It can also come from endocrine disturbances, which leads to chronic anovulation. It also could be from an ovarian insufficiency or failure. Those are kind of the three sort of broad categories, and there's a bunch of different things under each of those that can lead to it. We won't go into, I think we covered this when we talked about hormonal contraception as far as the process of the menstrual cycle itself and the levels of estrogen, progesterone, in kind of how they interact and respond appropriately to follicle stimulating hormone or luteinizing hormone, and how that whole kind of process goes. But basically when something in that process is out of sync, obviously it leads to a disruption in the endometrial growth and shedding, and can lead to amenorrhea. So a lot of the treatment options for amenorrhea, especially depending on the underlying condition, sort of circle back to dealing with hormonal contraception and things like that.
Right. You'll see that as a recurrent theme for treatment for a lot of these that we talk about. The pathophysiology, it can be dependent on what organ system or specific condition is going on. For instance, with the uterus, there can be congenital uterine abnormalities that can cause amenorrhea. With the ovaries, there can be gonadal dysgenesis. This is frequently associated with Turner syndrome. This is common. Also, chemotherapy or radiation treatment can affect the ovaries negatively and cause amenorrhea. And then there's the anterior pituitary piece. So there can be pituitary prolactin secreting adenomas that are going to increase prolactin and suppress the hypothalamus pituitary ovarian axis. There's also medication. So we'll go through a few specific ones, but I always think of antipsychotics as well as verapamil that can increase prolactin and suppress the HPO axis as well. With the hypothalamus, this is kind of how we mentioned competitive athletes. Exercise can decrease pulsatile gonadotropin releasing hormone secretion, thus decreasing follicle stimulating hormone and luteinizing hormone secondary to low body fat. And similarly, that can be associated with weight loss related to eating disorders as well. And it's kind of the same mechanism. No relation between the two as far as the cause, as far as why they happen, but as far as what happens down the line, that can be the same. And then PCOS would be related to the hypothalamus as well.
So from a symptom standpoint, obviously the first big one that we're addressing is the lack of menses as well, is kind of where the amenorrhea definition comes from. However, there's oftentimes associated complaints of vaginal dryness or decreased libido and even infertility that come along with amenorrhea as well. Some other things to kind of keep in mind, like Cole was saying, the weight loss or even weight gain as well. If there's been big fluctuations in body weight, you want to make note of that. So it's important to kind of ask the question and also look back maybe on the patient's weights that have been kind of trended over appointments. If there's a patient that's you've seen before, because if they are having some kind of eating disorder, they may not want to bring that up or anything like that. So just kind of looking at their weight over time. Other signs of like androgen excess can be important too. So looking for things like the presence of excessive acne, hair either growing where it's not supposed to grow or hair loss, alopecia, hair where it's supposed to be not growing. Things of those nature that basically are typical like androgenic effects that we would expect, because that's one of, obviously, especially in like PCOS, things like that, the androgenic activity can definitely lead to this as well, and those androgenic processes will probably be noticeable.
Isn't it just so sad for men? I mean, that that's just a part of having androgen, is just losing your hair.
It is. We have it so hard.
I tell you what. Yeah, as we're talking about menstruation-related disorders, I'm complaining
Cole,
about losing my hair.
See what Cole does? He brings it back around. This is unbelievable. This is a women's health podcast episode, Cole.
As we age, I have to think about it more and more.
No, it is bad. I see myself like in pictures and stuff. In fact, one of my students took like a picture when they were over here doing the podcast with us, and took a picture of me like I was just adjusting the things and like had my head down. I was like, oh no, I'm so bald.
My dad has been like actually bald since he was probably my age, 28,
really?
29. Yeah, he's just started to lose it so bad he shaved it, and
that's the move. You just gotta let it go.
You just gotta let it go. It's
we're gonna hair transplant.
It's a shock at first. I can only imagine. You have to get a tan on it because it's got to be really white.
Yeah.
For me at least.
For Cole at least.
For me, yeah. So
AJ, are you gonna shave your head?
Probably not.
Yeah,
I'm gonna hold on for a while.
Hold on for a while. AJ's already got the idea. He's like, let people know what I look like bald now. Oh, yeah. And then that way, worst case, no surprise.
I'm just not looking forward to it.
AJ, you want to run through the lab tests we should be getting?
Let's do it. Always first, and that's what I've checked with amenorrhea is the pregnancy test. It's one of those things that the first sign is the first couple weeks after you're supposed to be having your menses is, hey, let's see if I'm pregnant. If not, the next thing I would definitely check is the serum follicle stimulating hormone and the luteinizing hormone to check to make sure there's no further hypothalamic issues, secondary amenorrhea issues, and then prolactin as well. One of the things that we're going to move into is hyperprolactinemia. That's my favorite word ever. It's the word of the month for me. But prolactin is one of those suppressive hormones that can also lead to the decrease in estrogen and things. And then if we suspect PCOS or other hyperandrogenic conditions, then we would definitely have to test for the free and total testosterone, the dehydrotestosterone, fasting.
That was good.
Fasting
glucose, and then a lipid panel as well.
I was waiting for that word, and I was just going to point out that it has to be hyperprolactinemia.
DHPT.
Dehydroepiandrosterone.
There you go.
Dehydroepiandrosterone.
Yeah. Close enough.
I love it.
Good job, boys. Nailed it.
Nailed it.
These are my favorites.
So
that needs to be your new favorite.
We mentioned antipsychotics. So now we're talking about hyperprolactinemia and medications that can cause that. We mentioned antipsychotics. We mentioned verapamil. Specifically, the typical antipsychotics are more likely. Older ones like prochlorperazine, chlorpromazine, also haloperidol, and then atypical antipsychotics like risperidone. That annoying saying about it being more typical.
The most typical atypical?
Yeah, I wasn't going to say it.
Why?
Because it's like annoying. Everybody says it.
Is that annoying? Okay. Sorry, guys.
You said that last time.
Did I?
Yeah. You were like, that overused phrase, it's the most typical atypical.
Oh, well, I don't remember that.
I was just trying to, agree with your sentiment.
You didn't want me to make fun of you.
I didn't want you to make fun of me for saying
Oh, sorry, dude. I don't mean to be a bully.
All right. Well, I went the other way around. I made fun of you.
Yeah, that's how rude.
Then antidepressants, but more... like not the common SSRIs and things like that. Chlamypuramine, which is a MAO.
TCA.
It's a TCA.
And I think that's one that you typically won't see nowadays, except I will say that
I have seen it, but it was in like an older patient who was on it for a long time.
And there is good evidence with that one as an adjunct therapy to like fluvoxamine and OCD patients. That's kind of where I tend to think of that one. So in those patients, if you're dealing with, those types of situations, I think that way be one to at least be aware of. Since we don't deal with that med very often, that can be an easily overlooked thing.
Yep. And then GI meds like metoclopramide as well.
Which I think that one's interesting too, because it's like the metoclopramide, it already shares the tardive dyskinesia, EPS type symptoms with.
It's not the cleanest drug.
No, well, it's got like the similar, from a mechanism standpoint, structural standpoint,
it's like an
similar to the
antipsychotic.
antipsychotic, but yet
dopamine
used very, very differently. But yeah, that one I always think of. I feel like we always think tardive dyskinesia with that one, but we forget that that's also the concern with long-term use of metoclopramide is that increase in prolactin level.
Yep.
Easily overlooked. I've definitely seen patients that are on that drug way too long.
Yep.
They get put on refills and just never taken off.
But we didn't overlook it.
We didn't overlook it.
I'm sure there's other things we're overlooking.
I would say definitely.
We didn't overlook this, though.
Go us. All right. So, amenorrhea, first thing, we're checking pregnancy test, making sure that's negative. If it is negative, then we're kind of assessing a possible underlying cause, specifically, getting a patient history and kind of like their social history as well, if they're doing sports or how often they're working out, things like that. Because it is going to be important to assess for any, over-exercise, as well as looking for any signs or them explaining any kind of situation that would lead you to think that they may have some sort of eating disorder, anorexia, bulimia, something along those lines. If that's the case, then we can often get by with simply correcting the lifestyle that is leading to that, and then oftentimes they will have an improvement in their symptoms. If not, then we're typically going the estrogen progesterone combo route, usually just a standard combo hormonal contraceptive option, and we'll go into that in a little bit more detail. If they have a hyperprolactin level, then we are going to potentially start a dopamine agonist, which we'll discuss. But again, that's kind of, we want to address the whatever caused that to begin with. If it was a medication versus something like PCOS or what have you. If they do have PCOS, we're sort of looking at whether or not they are wanting to become pregnant. So if they found out they had PCOS because of the infertility or something along those lines, then we have to decide if they're actually trying to become pregnant or not, and that can change our strategies for therapy, and we'll discuss that as well. And then also kind of looking at, hey, have they started a different kind of hormonal contraceptive? Have they just gotten a medroxyprogesterone, like Depo-Provera, and then no one told them that after a few doses that may lead to amenorrhea? It's one of those things that getting a good history can help us kind of figure out. It may be something simple. It doesn't always mean it's a catastrophic hormonal imbalance or anything like that. But I guess we'll start off with we already mentioned the anorexia or excessive exercise. If we are going to go the medication route, let's say it's an athlete who just doesn't want to, stop training like they're training or what have you, then typical combined hormonal contraceptive is what we would go with. The same kind of adverse effects, though, that we would think about with regular hormonal contraceptive for anybody, is what we would still have to be at least a little concerned with in the case of a patient treating amenorrhea. So increased risk of thrombosis and triglycerides can go up. Things like potential for hypertension, weight gain, can change mood and even lead to depression in some patients. So just kind of making sure at least the patient understands the risks and whatnot. And it may even be a situation where that keeps them from wanting to go on therapy and maybe adjusting the lifestyle management by itself. Depending on how old the patient is, you may see some recommendations for like an estradiol patch or some sort of like a Premarin, like equine estrogen conjugate, but those are typically going to be safe for patients who are much older, who have had like a hysterectomy or something along those lines. We typically want to use the combo estrogen and progesterone in patients who have an intact uterus to avoid unnecessary complications down the road and unnecessary risks.
Right.
I think we have an episode maybe 6 to 12 months ago that we talked about hormonal replacement therapy.
I think it was about a year ago.
So check that episode out. We go into a lot more detail on that, obviously. But we would expect with the combo hormonal contraceptive for menses to kind of resume within 1 to 2 months of them starting therapy. Obviously, it's going to be a little bit different depending on each patient to patient, but it is something that that's the general idea of how quickly we'd expect the patient to respond.
Yep. And then another cause, hyperprolactinemia. Before we talk about that, did I tell you that I had a student just shadow me the other day, not even on rotation with me, who says she's listened to like all our episodes. Isn't that crazy?
All of them?
Well, she says she listens to it on her commute, like back and forth from wherever she lives in South Carolina.
Sweet.
Yeah. So
That's awesome.
shout out to her if she's listening.
Yeah.
It's nice to hear hear from listeners just randomly when they're students with you.
Yeah, that is cool.
But yeah, hyperprolactinemia. So if you can't, the first option could be discontinuing or switching the offending agent if it's increasing your prolactin levels. If that's not possible or if that doesn't work, there is a way to treat it. So dopamine agonists would be that way. There's a couple of options, old drugs that you probably heard of, bromocriptine and cabergoline. Bromocriptine works. It normalizes prolactin levels in about 58% of affected women, but cabergoline has the same effect within about 85% of women. So it generally would be preferred, I would think.
Tends to be a little bit more
there are
efficacious.
some adverse effects to be aware of: GI upset, orthostatic hypotension, headache, nasal congestion, and you do need to do some labs. So baseline and weekly prolactin levels should be measured with dose increases until the menses resumes. And then if it does, you still continue therapy for a time, 6 to 12 months following the return of menses, and continued normalization of the prolactin levels. And then it could be discontinued.
Yeah. And we're going to do PCOS as a completely separate topic. So we'll come back to that one because it's not always just amenorrhea that's the symptom. But the other thing I want to address before we move on is if a patient, in the case of an adolescent patient, if they are having amenorrhea, something that needs to definitely be promptly identified as far as the cause, because amenorrhea, especially in adolescent, could be indicative of hypoestrogenism, which can negatively affect bone development. And so in addition to sort of treating and eliminating the underlying cause of the amenorrhea, making sure patients, especially adolescent patients, are receiving adequate amounts of calcium and vitamin D to hopefully aid in their bone strength and development. And then obviously, with the estrogen being so important for bone health, if the patient is has hypoestrogenism, then we are going to potentially give estrogen replacement. Again, that's out of the realm of this topic, but that may be the case, especially in the adolescent patients.
Mm-hmm.
So,
yep.
Switching to the other side of the spectrum now.
Yeah, you want to start that one off, AJ?
Let's do it. So moving into that heavy menstrual bleeding. Very familiar with this. The menstrual bleeding defined as greater than...
And his girlfriend just broke up with him.
Terrible. Greater than 80 milliliters, which is about this much per cycle of menstrual bleeding, lasting greater than 7 days per cycle. So that's just over the course of 7 days. If you're losing 80 milliliters or more, you should notify your doctor or healthcare provider that you're having sort of heavier flows than normal. Hematologic causes could be Wildebrandt factor. That's factor 7, defect that causes the impaired platelet adhesion and increased bleeding time. Another hepatic cause would be cirrhosis, and so you'd have damaged estrogen metabolism there. And then endocrine causes would be hypothyroidism, of course, with the alterations in the hypothalamic pituitary ovarian axis. Mm-hmm. There we go.
Yeah, nailed it.
Killing it. And then, of course, just your regular uterine causes, fibroids, endometrial polyps, and gynecologic cancers of the sort.
Yeah.
I think the cirrhosis one I always keep that, that always, pops in my mind because, when we're treating Hep C, one of the things we'll look at, especially in a patient with cirrhosis or a suspected cirrhosis, we'll get an INR or a PT level. And kind of because the INR usually will start to go up the more fibrosis or cirrhotic the patient becomes. And then I think the big thing with heavy menstrual bleeding is, we always think of the iron deficiency, those types of things that we're worried about, but also just the decrease on quality of life from a social, professional, family. There's lots of different aspects that can really affect the quality of life. So this may be something that is really bringing the patient into a negative spot from a mental health standpoint, and so it needs to be addressed and obviously treated.
Right. So it's important to note that a diagnosis can be made based on those subjective factors versus if they didn't quite hit the 80 mLs for 7 days.
Yeah, because that's such a textbook way of saying that, but very rarely is that going to be actually utilized clinically. So at least in primary care, I should say. I think from a patient history standpoint is really what that's where that's kind of made from.
So you would want to get some baseline labs in this instance. So complete blood count first, also ferritin levels. This goes back to some of the concerns Mike was mentioning with iron deficiency anemia. Hemoglobin, hematocrit, And then if the patient has potential for a coagulation disorder, you want to get some labs related to that. PT, APTT, INR, and then some factors like some clotting factors like factor 8 and factor 10. Some other diagnostic tests that might be needed depending on the situation, pelvic ultrasound or MRI, pap smear, endometrial biopsy, or a sonohysterogram.
So I think the next, kind of step, once you've established the fact that the patient does have heavy menstrual bleeding, they want to start treatment. The next question is going to be, do they desire contraception? Because if they do, then we're going to go that route of hormonal therapy. If not, then actually the first line is NSAIDs, especially during menses. Some patients will end up taking them, throughout the month, but at least during menses to kind of alleviate the heavy menstrual bleeding during the time, obviously. But this always, first thought, like you might be thinking, like, well, doesn't NSAIDs cause the risk of bleed? And the reason for the NSAIDs being useful in this particular case is because the certain prostaglandins are elevated in patients who are having heavy menstrual bleeding. And so that's what you're actually blocking. So it's not, don't think of it in regards like we would with a GI bleed or something along those lines. This is basically blocking or reducing those prostaglandins that are directly stimulating the menstrual bleeding, the heavy menstrual bleeding.
Right.
Pathology. Also,
probably patients who are self-treating would think to go to NSAIDs if they're having dysmenorrhea or pain. Mm-hmm. And I probably wouldn't think of it as much wouldn't think that it could help with heavy menstrual bleeding, but
it definitely does. I think naproxen seems to be a good one because it's so non-selective as well. Instead of going one way or the other, it covers a lot of our prostaglandins regardless of their origin. So NSAIDs, naproxen 550 or Anaprox DS BID, at least during the time of menses, if not longer, is the one commonly used. Sorry, Cole, I jumped in front of you.
No, that's fine. There's also tranexamic acid. It's branded as Listida. So this is an interesting drug, and this is the only thing I've seen it used for. Is this the only thing?
I believe they can use it in certain like trauma situations and things as well.
Very interesting. So it's kind of like a pro-clot drug. It displaces plasminogen from fibrin, and this results in inhibition of fibrinolysis. So it has some adverse effects associated with it: abdominal pain, headache, back pain, muscle cramps. But because it's kind of pro-clot, then it would be contraindicated in patients with an active or a history of thromboembolic disease. Interactions, the effects of Listida may be increased by estrogen and progestin derivatives, which is significant because a lot of these patients might be taking those.
Well, and I think too, it's one of those things. That's why we want to go down one path or the other. Yeah. I mean, NSAIDs is one thing, but if you go this route, you definitely don't want to be using them together in most cases.
Yep.
So the last thing we want to do is increase the risk of a clot.
Yes.
The other option, if we are going the contraceptive route, would be, technically speaking, any combined hormonal contraceptive can be used. However, there is one agent that is like approved specifically for heavy menstrual bleeding that is kind of unlike the others. It's a quadriphasic derivative, so it's got estradiol valerate and Dynogest is the progesterone, and the brand name is called Natasia. And it's separated by basically days 1 and 2. There's 3 milligrams of the estradiol component. Then days 3 to 7, some of the estrogen component goes down as the progesterone is introduced. 8 through 24, the estrogen stays steady as the progesterone goes up. And then days 25 to 26, estradiol's down even further, and the progesterone is discontinued. And then only days 27 and 28 are the placebo. So it's one of the only hormonal contraceptive combos that is like the most similar to like the actual flow and rise and fall of these estrogen and progesterone naturally. So that's kind of like its claim to fame for this particular situation especially.
And then you might be thinking that there are certain contraceptives that we use that can effectively cause no bleeding because they can prevent a menstrual cycle.
They induce amenorrhea.
They basically induce amenorrhea, and so you would think that would be beneficial in this situation. So one of those are the levonorgestrel intrauterine devices, branded as Mirena, Skyla, Kyleena. You've probably seen commercials for them. they're generally considered the most effective treatment to reduce menstrual flow. A 70 to 90% reduction in blood loss has been observed with its use. It's also resulted in the postponing or canceling of endometrial ablations that were surgeries that were scheduled, or hysterectomies due to its effectiveness.
Yeah. So at least, if nothing else, buying you some more time before undergoing surgery in some cases.
Some severe cases.
I think it's important to make sure that we know that this is the progesterone IUDs, though, instead of just saying the term IUD by itself, because Paragard, the copper IUD, is definitely not going to help with this. That actually causes the worst type of menstrual bleeding compared to any other device. So make sure that
used.
Yeah, it's the most effective as far as like contraception goes. We use it all the time at our clinic. Our women's health, nurse practitioner uses it quite a bit, but it does very, very effective for contraception. Definitely leads to heavy bleeding though. So don't get that confused with the progesterone for this. For treating heavy menstrual bleeding, you will be sorely disappointed, and your patient will not be happy.
No.
They also have progestin-only tablets that are an option depending on how long of a course you want to treat. There's some debate there, but the ones that are typically utilized are norethindrone acetate or medroxyprogesterone acetate or Provera. The older thought process was that they would do a cyclic progesterone therapy for 14 days. That would help to reduce menstrual blood flow. However, depending on what study you looked at, it was a reduction in blood flow from only 2% up to about 30%, depending on, again, the study. But when they started looking at longer courses where they administered the progesterone for 21 days, starting on day 5 after the onset of menses, and then when they kind of followed up with those patients, they had a reduction in menstrual blood loss from 63% up to 78% in those patients. So seems to be a little bit more effective, possibly more side effects associated with it, but does seem to be more effective. And from what, at least in my anecdotal experience of working with our providers, it seems to be the course that we typically prefer.
Yeah.
So overall, it looks like you just want, with NSAIDs, is a reduction in blood loss over 1 to 2 months. And then with the tranexamic acid, just a reduction in blood loss with menses. You should notice it over the first month, and then with improved hemoglobin and hematocrit after 3 months of therapy compared to the baseline. And then with the combined hormonal contraceptives, the levonorgestrel IUDs and progestin, not the cyclic, reduction in blood loss.
And the cyclic.
And the cyclic.
Yeah.
And the cyclic. A reduction in blood loss with menses over the first to 2 months of therapy, and then improved hemoglobin with hematocrit over 3 months of therapy compared to the baseline.
Yeah, and I think that's the important thing, is to let patients know the time frame, because don't give them realistic expectations of how quickly this is going to take effect, and make sure that they understand it could take a couple months and couple cycles to actually take hold.
Right. All right.
PCOS.
Finally getting there. We mentioned it a few times.
Yeah. So go ahead.
Yeah, so polycystic ovary syndrome is what it stands for. In reproductive age women, it's the most common cause of abnormal uterine bleeding associated with ovulatory dysfunction. So you'll hear this referenced a lot when it comes to fertility. So symptoms can include amenorrhea, oligomenorrhea, intermenstrual bleeding. It's a disorder of androgen excess accompanied by ovulatory dysfunction, and or polycystic ovarian morphology. It's often accompanied by insulin resistance. So you'll hear us mention metformin as a treatment option. Risk factors for the metabolic it's a risk factor for metabolic syndrome, type 2 diabetes, dyslipidemia, that sort of thing. So.
And as far as the labs and kind of all that, we've already sort of mentioned, but again, with this, you are expecting to see some of those androgenic signs as well. So acne, maybe some unwanted weight gain, hair growth we're not looking for. And then, typically we're thinking infrequent or absence menses, but there are cases too where, depending on the patient, you could present with even heavy menstrual bleeding. So it's not always always amenorrhea or oligomenorrhea. So the labs, though, are still going to be the same, like we've already talked about, as far as the pregnancy testing and all that. And then that's where, like AJ had mentioned, maybe getting a freer total testosterone, some other hormonal levels, fasting glucose, lipid panels, things of that nature.
Yeah. Increased weight can be a risk factor. So as far as non-pharmacologic options, weight loss of 5 to 10% may result in improved menstrual regularity, ovulatory function, reduced hirsutism, increased insulin sensitivity, and may improve response to fertility treatments. The first line therapy is what we've been mentioning for a lot of them, which is a combined hormonal contraceptive, estrogen plus progesterone. It increases sex hormone binding globulin, which bind androgens and reduce their circulating free concentration. So that's how they're going to decrease the circulating androgens. Important to note that the contraceptive should contain less than or equal to 35 micrograms of ethinyl estradiol. We'll talk about some options that have that. And it should contain a progesterone that exhibits minimal androgenic side effects. So just so you know, progesterones can cause some androgenic side effects. There's some that are minimal or some that are anti-androgenic. So minimal would be norgestimate and desogestrel. And then drospirenone would be considered an anti-androgenic progesterone, but it is potassium sparing. So you have to be aware of monitoring their potassium for hyperkalemia with drospirenone.
So we'll go, just to give you a couple examples, like Cole said, of some of the commercially available products that have these progesterones in it. Things like orthocycline or Sprintec is norgestimate, along with ethinyl estradiol. They also have orthotricycline, which is another one that's it's a tricyclic, obviously, or a triphasic, not tricyclic, triphasic formulation. Things that have desogestrel would be like Riclipsin, and then Yasmin and Yaz are the two big ones. There's also Biaz and a few others that have drospirenone as the progesterone. That's that, like Cole mentioned, the anti-androgenic component. But if the patient does not want to be on hormonal contraception, so let's say they're actually trying to become pregnant, because that's, so like I said earlier, one of the ways that this kind of comes about is patients, dealing with infertility. If the process is them, they're wanting to treat their symptoms, but and induce ovulation, and specifically in PCOS, we can use an aromatase inhibitor, letrozole, or Femera is the brand name. That would be the option to go with instead of the hormonal contraception, which is obviously not going to help with fertility at all. And so this is commonly used in this regard nowadays. Adverse effects, you just kind of give patients the heads up on, it would be things like GI complaints. It can lead to edema and flushing. It can affect cholesterol levels and increase the lipid panels. You can see weight gain that's unwanted, even like things like bone pain. And so definitely not a mild drug, and definitely something to let patients know, like, hey, this is potentially going to lead to some side effects, just so they can kind of be ready for that. But it's an option for patients that are seeking fertility.
Yeah, and there's PCOS. A lot more intrusive fertility treatments too. So
yeah, that's definitely not the only one.
Right.
So yeah, what about metformin?
Yeah.
I don't know. What do you think about metformin, AJ?
I think it should be considered in women and adolescents with PCOS, like for management of the metabolic features when lifestyle changes aren't sort of achieved. That 5 to 10% weight loss. It improves insulin sensitivity, and it can also reduce the circulating androgen concentrations and improve ovulation rates. There's a lot of different mechanisms that
metformin's got a bunch. But I think I got asked by my PA students. They were asking me about, like, well, could we use something like a GLP-1 here instead of metformin? But that's the piece that I think we always forget about, specifically in PCOS, is like it actually can help reduce those circulating androgens. So it's like that very,
it's not only
nuanced,
metabolic.
Right. It's that nuanced mechanism that metformin has. If
that was the case, we'd be giving them tirzepatide.
Right. And one thing, this is off topic, but it's something I ran into myself, and I figured I'd share it. I told my PA students the same thing. If you ever have a patient that you're starting on metformin for, diabetes typically, obviously, and they start having heavy menstrual bleeding after they start the metformin. Have you guys ever run into that? Like, heard of that?
Never heard of that.
So at first I hadn't either, but the patient called me and explained that, and then I started thinking about it after I talked to the patient, and the whole mechanism behind PCOS came into my mind, and so I started looking up case studies, and it could be a sign, not necessarily, but could be a sign that the patient has underlying, like, endometrial hyperplasia or some other more serious issue going on. And so I called the patient, and it turns out they do have, I won't go into it, but a history of certain gynecological cancer history. So they were calling their OBGYN and getting it was not the return of that, but they were, it was directly in dealing with the endometrial lining, things like that. So something that we don't tend to think about, especially in diabetes management and whatnot, but could definitely help if you run into that, and it's not something to be overlooked.
Very interesting.
Throw that out there.
It's new for me.
Yeah,
it's a good catch.
Okay, so that's PCOS, right?
And summary of it.
Yeah, summary of it. Let's move into dysmenorrhea. So I kind of referenced it earlier, but that's pelvic pain and cramping occurring with or just prior to menses. So very common. The prevalence rates range up to 90%, but they don't know exactly because it's not always reported, but up to 90%, very common. There's primary and secondary dysmenorrhea. So primary would be pain in the setting of normal pelvic anatomy and physiology. The cause of the pain is multifactorial, the release of prostaglandins and leukotrienes into the menstrual fluid, causing an inflammatory response, and then vasopressin-mediated vasoconstriction. But then there's also secondary dysmenorrhea, which is pain associated with an underlying pelvic pathology. You would want to be more concerned for this in women over 30 years of age without a history of dysmenorrhea previously. They could be endometriosis, a current history of pelvic inflammatory disease, fibroids, things like that. But this is significant. It can cause a definite interference with work or school attendance, lower overall quality of life. So treating this and getting it under control is important.
Yeah. All right, so we'll go through these individually, but typically speaking, we'll start off with some non-pharmacological interventions, which I will say, depending on this practice setting that you're working in, if you're in primary care, family medicine, and there are patients coming to you, they've most likely tried non-pharmacological options over by themselves. So mostly we're past this step, but just we'll say we're not. We do want to make sure that patients have at least attempted those, and if not, then we can at least add those on to our first line options, which are typically NSAIDs, monthly NSAIDs beginning at the time of symptom onset. If that is still not effective, then that's when we're going to start escalating to our hormonal contraceptive options, like we've been previously mentioning. Just to kind of mention some of the non-pharmacological treatments, the one actually that has the best evidence, which this probably isn't really that surprising, but topical heat application, whether it be a heating pad, topical patch that you can get for heat on the muscle and the types of aches and things like that you'll see over the counter, those applied to the abdomen can definitely be effective and have actually been shown in studies to be as effective as 400 milligrams of ibuprofen dosed 3 times a day. So all the other types of over-the-counter or herbal remedies, so things like fenugreek or ginger root, valerian, zinc sulfate, fish oil, all of those, when they look at the 2016 Cochrane review, which was a really, really big study looking at basically all of their evidence, came up to the conclusion that all of the studies that have looked at these have low to very low quality evidence. So, I think in my mind, it's one of those things that if a patient is not on their medications, otherwise healthy, and they want to try something like this that they consider to be natural or what have you, I think it's worth a try. But I think as the clinician, you need to have very realistic expectations of how well these therapies will work. There's also some low and very low quality evidence behind acupuncture and acupressure in another Cochrane analysis that was also published in 2016. So something to think about. Again, if you have a patient who's just adamant about using natural products, there's a few things that at least have some kind of data, but I wouldn't put a ton of faith in their efficacy.
Right. And by the time patients get to you, like Mike said, they've probably already tried NSAIDs. But depending on what they've tried, the treatment of choice is naproxen. Ask them how they're taking it around menses. It's ideal to take it 1 to 2 days prior to the onset and then through the first 2 to 3 days of menstrual bleeding. There's also meclofenamate, which is that approved in the U.S.?
I believe so, yeah.
Okay. Haven't seen it myself, but there's meclofenamate. And there's mefenamic acid. Mefenamic acid. Man, that one got me.
It did.
Oof.
Unbelievable.
It's usually not given for longer than 3 days. Generally, Tylenol acetaminophen is considered inferior to other NSAIDs like naproxen. in this treatment or for this disorder. Just be aware of that. And then when they come to you, it's probably at the combined hormonal contraceptive phase. This would be considered if the NSAIDs are contraindicated or they don't want to be used or they're not effective. Just some notes. One study suggests that a contraceptive containing a potent progestin like levonorgestrel may be more beneficial than others. Compared to cyclic regimens, continuous regimens may result in more rapid pain reduction. For example, the brand name Ssris, which is 84 tablets on and then 7 tablets of placebo, would be an example.
And to answer your question, yes, it is available in the U.S. still.
Okay.
But definitely, and it actually has the FDA indication for either dysmenorrhea or heavy menstrual bleeding, but has its box warnings for increased cardiovascular and thrombotic events. So definitely not one you see very often, but still out there.
Like, can you pop into a pharmacy and find that? Or is that prescription?
It's prescription.
Oh, okay.
Yeah.
I've never seen it.
So I remember we had one patient that was getting it when I was working with Walgreens years back.
Interesting.
So I have seen it before, but it's very uncommon. All right. So the other option besides using the oral hormonal contraception is, again, going to our IUD or our Depo-Provera, our medroxyprogesterone injections. Basically, the pelvic pain of dysmenorrhea is thought to be associated with that prostaglandin release during menses, and so these agents are inducing amenorrhea, basically. So you're stopping the dysmenorrhea by stopping the menses. So that's the thought process.
Seems like it'll work.
It does seem effective, but it can take 6 to 12 months sometimes for that to fully take effect. So again, it's usually something that we try hormonal contraception orally first, and then go to these, unless the patient's just wanting these anyway for contraception use. Then we kind of have these third line.
Can't have painful menses if you don't have menses.
You sure can.
I would imagine so.
I wouldn't imagine.
Well, there can be cramping and not bleeding.
That's true. But yeah.
But that's still.
Yeah.
Is it still menses?
Yeah, I mean,
It would be from the cycle. It's part of the cycle still.
Yeah.
Yeah.
So
Okay.
let's just drop it there.
We'll leave
so we
it there.
don't, because we're literally teetering on the edge of looking stupid.
We're trying to keep it really high level for a reason.
And
Cole, don't ask stupid questions.
Yeah,
on the
Cole,
pod.
please stop talking. No,
Okay.
my brain's too tired right now to think about anything past what we're already talking about.
And with that, we'll move into PMS and PMDD. So PMS, premenstrual syndrome, PMDD, premenstrual dysphoric disorder. PMS is represented by a cyclic pattern of symptoms occurring in the last week of the menstrual cycle that resolve when the menstrual flow starts generally. The diagnosis requires at least one moderate to severe somatic or psychiatric symptom, we'll go over those, to be present in that last week of the luteal phase for at least 3 months. And then you can diagnose PMS, right?
Mm-hmm. So some somatic symptoms would be things like abdominal bloating, breast swelling or tenderness, headache, muscle or joint pain, swelling of extremities, weight gain. When you would deal with like this, the psychiatric type symptoms or the affective symptoms is how you'll oftentimes see it relayed. They can be outbursts of anger, anxiety, depression, difficulty with concentration or just confusion, irritability, social withdrawal. But again, that's basically where the patient is having these symptoms 5 days before menses, and that, for the last 3 menstrual cycles. So these symptoms are not staying with them the entire, month or months, because it's not something that's how the difference between just underlying general depression or something along those lines versus something that's directly associated with something, like premenstrual syndrome or PMDD.
Right. And that kind of goes into the diagnosis of PMDD. So some women experience more severe PMS symptoms, and that's effectively what PMDD is. It's just having more of those symptoms that Mike outlined. At least 5 symptoms need to be present in that same time period, the last week prior to the onset of menses, and they generally may improve within the first few days after onset. Not only that, so you can have PMS diagnosed without an effective symptom. PMDD has to be at least one of the 5 symptoms needs to be an effective symptom. And like Mike said, can't be attributable to another underlying mental disorder like substance use or other mental issues.
Yeah. So some things to consider, some non-pharmacological treatments would be things like just minimizing the intake of caffeine, refined sugar, sodium, and also increasing exercise as well can help eliminate some of the symptoms, especially in regards to PMDD. Some vitamin or mineral supplements that have some evidence to back them up would be like B6 or calcium carbonate can help to reduce some of the physical symptoms. Also, cognitive behavioral therapy has been shown to have some moderate efficacy in certain studies. However, the problem with CBD is CBT, not CBD. Is
Who knows? Might be effective.
maybe
it's
that might
effective
be
for everything else,
effective
right?
for everything else.
At least that's what the
At least
sign
that's what they
says
say.
at the gas station.
Sure does. And that guy doesn't lie. But the frequency and the duration of therapy that needs to be done to truly get an efficacious outcome is not clearly been defined. So that's going to be more clinician, therapist specific, and patient specific. So until they kind of establish that, there's not like a great guideline to go off when it comes to cognitive behavioral therapy specifically.
Right. So first line agents for PMDD specifically would be SSRIs. So we got your standard ones: Prozac, Zoloft, Paxil, Celexa, Lexapro. We'll talk about what might be preferred. But research, interestingly, this is very interesting to me. Research evaluating the dosing of these continuously or only during the luteal phase. Do you say luteal?
Luteal?
Yeah. Isn't that what the correct way to say it?
I don't know.
I think it is. I like luteal, but
I like
yeah.
luteal.
Luteal, I think, is right. I digress.
I say it perfectly, so that's fine.
Taking it only during the luteal phase has illustrated similar efficacy between the two regimens. Of course, we know that sexual dysfunction can be an issue with SSRIs, so decreased libido occurs at a higher rate with continuous dosing. So are we saying that we could just take it for a week or so and then stop? I mean, discontinuation issues, you know what I'm saying?
Yeah, so, and this actually came up with my PA students. They were asking about this, and I think it's one of those things that it depends on kind of who you ask, because like technically speaking, there is both continuous dosing regimens that are available. So like fluoxetine, for example, they talk about the luteal phase dosing regimens that you can do, or symptom onset dosing regimens, where it's so, for example, the luteal phase, you would do 10 milligrams once daily during the luteal phase of menstrual cycle only, beginning therapy 14 days before anticipated onset of menstruation, continued to the onset of menses over the first month, and then you can increase to 20 milligrams once daily during the luteal phase, but it's just during those second 2
So
weeks.
they mentioned fluoxetine specifically.
Mm-hmm.
I mean, its
Well,
half-life
that's
is so long. I mean, it takes a while to get to steady state. I mean, if it works, it works. But that's so interesting.
Yeah, I need to look into the underlying mechanism for that. But yeah, I think in doing fluoxetine, if I remember correctly, I feel like fluoxetine had a formulation that actually was like Seraphim or something like that. Wasn't it designed for like?
That brand name sounds familiar, but I can't remember what it is.
I'm just trying to look it up real quick, but it was designed for like specifically that.
Well, I'll mention that birth defects can be a concern with SSRIs. You'll see in the old labeling, you'll see Class C for some, Class D for others. So in a large-scale analysis showed that birth defects, including anencephaly, atrial septal defects, right ventricular outflow tract obstructions, can be 2 to 3.5 times more frequent with paroxetine and fluoxetine use. So that's probably where you get the old Class D recommendation from. So if that's a concern, then you'd want to avoid fluoxetine and paroxetine in this instance and use one of the others like Zoloft, Celexa, or Lexapro.
Yeah, the Prozac weekly. I might be thinking of something definitely different, but yeah, it's because it's utilizing the long half-life to not do daily dosing. But
Right.
That could be something different. I might be getting myself confused. It's very possible, AJ.
Doesn't sound right. But we got selective serotonin, norepinephrine reuptake inhibitors is the last option. With venlafaxine, Effexor, it results in a 50% or greater improvement in symptoms, and 60% of treated patients compared with only 35 in the control group. So It seems to be effective somewhat for the affective symptoms.
Yeah.
So those are first line. We also have, of course, some combined hormonal contraceptives that can be used. So the brand name Yaz is FDA approved to improve premenstrual symptoms in PMDD, as well as Amethyst, which is a newer one that I actually see a lot. Maybe it's not new, but I see it a lot. But it's been studied, resulting in a 30 to 59% improvement in PMDD symptoms as well.
I would tend to think, I guess it depends on what their somatic symptoms are. Because like with the bloating and
Good
things
point.
like that, I would go with Dysmenorrhea because of the anti-androgenic effects.
Yeah.
So I think it depends. That again needs to be patient specific. Everything's patient specific. There should never be
bloating isn't estrogen related.
I believe because the Dysmenorrhea, that's why it has like the
Oh yes,
like it's almost got like a spironolactone type effect to it, because that's why it's got the potassium sparing, and we're just dealing with the androgenic activity, which instead of increasing aldosterone, then affecting aldosterone specifically, it's decreasing the androgen activity, which shuts all that stuff off too. So it has like a diuretic effect to it.
Yep.
Yeah, because I think bloating and acne specifically, I always think Dysmenorrhea would be the one to switch to.
Gotcha.
But yeah, so if hormonal contraception is still not enough to take care of the issues, there are a little bit more intensive therapies. So for example, like the gonadotropin releasing hormone agonist known as Leuprolide or Lupron Depot. And this is usually something that's saved for a patient who has already tried these other options and was not getting symptom relief. It's definitely going to improve the premenstrual emotional symptoms as well as those somatic symptoms like bloating and breast tenderness, things like that. Adverse effects, we want to think things very similar to what we would think of with like perimenopausal or menopausal symptoms. So like vaginal dryness, hot flashes, bone demineralization, things of that nature. And because it is pretty expensive, it's an IM administration, it's got kind of limited use, and we definitely want to utilize some of the other options first, but if those are not effective and we definitely need to get the symptoms under control, then we have this in our back pocket.
Yep.
So there you go. Anything else that we have not?
We just touched on a lot of menstrual-related disorders, didn't we? And I don't think we've done some of those before, have we?
I don't know.
I don't
have to go
think
back
so.
and look. I'm not the guy that remembers what we've done.
I know. If we had, it's been forever. So.
Yeah. So yes, so make sure if you're a member of freece.com, you have an unlimited membership. Go use the password hormone and take the post-activity test. Get your ACPE-Accredited continuing education, 1 hour, and we definitely appreciate FreeCE for partnering with us again. Also, a big shout out to our main sponsor, Pyrls.com, pyrls.com/CoreConsultRx. It is a very up-to-date and new, aesthetically pleasing to the eye drug information app. I definitely think that it's going to be a very, very solid website and app as time goes on, and going to give the big guys a run for their money, because it's definitely very easy to use, and they're adding content every single month. So some great charts, really good up-to-date guidelines, as well as just standard drug information. So definitely check them out. We really appreciate Pearls for continuing to support the podcast. So make sure you give them a try. They have a really good free version of the app that you can use and assess whether you want to go further than that. But big thanks to them. Thank you guys so much. If you have any questions, comments, concerns, anything like that, make sure you send us an email. You can text us directly by going to the number that's in the show notes, reaching us on any of the social media platforms. And if you want more traditional style lectures, obviously check out the Patreon, where you can get my PA lectures that I do for all the different disease states for my PA students. We have like probably 110, 115 lectures on there, different disease states. You get all the PowerPoints that I have as well. And it's very, very cost effective in my opinion. So make sure you check that out. And just appreciate you guys sticking with us and listening to the podcast for all this time as we're steadily approaching what is it? This will be 4 years. We never decided last time. I think 5-year mark, 4-year mark, something like that.
We started in 2018, so whatever this is.
So whatever that is. So yeah, it's approaching that 4-year mark. Yeah, 4-year mark. AJ is my math guy.
Actually, I think January 2023 will be the 5 years.
Okay.
So I think we hit 4. We're approaching 5.
1, 2.
Yeah.
Yeah. This is ridiculous. I'm so brain dead today after working and everything. This is why we sound like morons at this point. So yeah, this is it's been a good time for us as well. So I appreciate everyone listening and sticking with us and all of our nonsense. Anything else, boys?
That's all I got.
All right. Y'all have a great night.